Hello, my name is Viksit Kumar. I am an instructor in the radiology department at Massachusetts General Hospital. I would like to thank doctors Yonina Eldar, Anthony Samir, Anantha Chandrakasan, and Canan Dagdeviren for giving me the opportunity to present our work. We are working on deep learning for home-based ultrasonic screening of pelvic organs. Pelvic organs include ovaries and bladder. In this work, we are targeting two specific pelvic organs, which are ovaries and bladder. Ovaries suffer from ovarian cancer, which is an aggressive cancer with high mortality rate. Treatment options include excessive surgery and removal of various pelvic organs. Urinary retention is the inability to void even when the bladder is full. Urinary retention is painful and often leads to urinary tract infection and can also lead to renal failure. There are limitations in current management for ovarian cancer. Clinical exams lack sensitivity due to the aggressive nature of the cancer. And urinary retention faces the challenges of excessive catheterization, which leads to urinary tract infection and poor time management of the patients and the nurses. Hence, there is a need to develop home-based ultrasonic screening tools for detecting ovarian cancer before metastasis and tools for managing urinary retention. Our goals include developing home-based screening tools for screening ovarian cancer and better management of urinary retention. These goals can be further subdivided into a database construction, algorithm development for detecting and segmenting bladder wall, and algorithm development for detecting, segmenting, and classifying the ovaries. Optimizing these algorithms to become power efficient so that they could be embedded into the ultrasonic patches. Development of an ultrasound patch which can either screen ovarian cancer or monitor bladder volume. And finally, the integration of power efficient algorithm into the ultrasound patch memory. Figure shows an ultrasound patch that can be placed on the body and continuously monitor bladder volume. The first milestone that we have achieved is constructing an ovarian database with 1700 ultrasound exams. 5 physicians have reviewed and annotated 500 exams. The second database that we constructed was related to bladder, and we had 2000 ultrasound exams, out of which 300 exams have been annotated by the 5 physicians. We have also developed algorithms which can detect ovary and the follicle and segment the ovary and the follicle boundaries. And we have also developed algorithms which can segment the bladder wall. Since small patch-based ultrasound devices need to be power efficient, we have quantized these algorithms to make them more power efficient and capable of performing deep learning algorithms in the memory of the device itself. This slide shows results from our ovary detection and segmentation algorithm. On figure A, you see the B mode image of the ovary and the presence of follicles. Figure B shows the ground truth, which was manually annotated by the physicians, showing the ovary in red and the follicles in blue. Figure C shows the predicted output of the algorithm with the ovary in red and follicles in blue. We can see that the predicted algorithm performs at par with manual annotations. An average die-score of 0.85 was obtained in a validation test set consisting of 85 ultrasound exams. This slide shows the results for bladder detection and segmentation algorithm. The anechoic region present in the image shows the presence of urine, and the hyperechoic region surrounding the anechoic region is the bladder wall. Figure B shows the ground truth bladder wall as annotated by the physicians. Figure C shows the predicted output of the algorithm, and we can see that it is at par with the physician's predictions. An average die-score of 0.90 was obtained in validation test set consisting of 55 patients undergoing the ultrasound exam. After developing the algorithms for detecting and segmenting ovaries and bladder, the next step was to quantize these algorithms so that they could be integrated with the ultrasound patch. Column 1 shows the different models that were tried for segmentation. Column 2 shows the result for full precision network when no quantization was done. And column 3 shows the results when network weight were quantized to 5 bit and input activation was quantized to 3 bits. DPLAB v3 Plus shows the best result in both training and validation for the full precision and the quantized network. A negligible drop in validation die score was observed in DPLAB v3 Plus, going from 89.27 to 88.78. This shows that we can use quantized networks which are lighter in weight and can be easily integrated into the ultrasound patch. Conclusion: we have developed quantized, power-efficient algorithms that can be used to detect and segment anatomical boundaries and are ready for integration into the hardware. Positive outcomes of the J-Clinic seed funding include a multidisciplinary, multi-institution academic collaboration between 4 different PIs. Dr. Yonina Eldar from MIT and Weizmann Institute of Science, who has expertise in signal processing, Dr. Anthony Samir from Massachusetts General Hospital with expertise in translational ultrasound, Dr. Anantha Chandrakasan from MIT with expertise in energy-efficient circuits, Dr. Dagdeviren from MIT with expertise in conformable decoders. Other team members who have contributed to this project include Kaustav Brahma, Zhang, and Viksit Kumar. The seed funding also led to external industry collaboration with partners from Texas Instruments, who have expertise in ultrasound analog front end. The collaboration also resulted in additional funding to the tune of $250,000 being raised.